So it's a real pleasure to introduce Professor Hickey, who is Professor of Obstetrics and Gynaecology in Melbourne. She's the clinical lead there for the largest menopause service in Australia. She has particular interest, of course, in menopause and cancer. And she's also influenced practice in the UK because she was the topic expert for the current NICE menopause guideline. She's probably often introduced as a leading researcher, but I think it's probably fairer to say she is the leading researcher in menopause and cancer. She led the COMMA initiative, looking at core outcomes to improve reporting of menopause trials. She leads the WAM study, What Happens After Surgical Menopause. She's led the Lancet series that I guess some of you will have referred to, and if you haven't seen it, please read it, and also her work in the BMJ. For UCL, she's collaborated on projects with Zach Nash doing the patient partnership with the James Lind Alliance, looking at research priorities in menopause, and with Amy Spector, looking at cognitive changes and dementia work. Through all of this, I think there's a real commitment to public involvement and to empowerment and trying to change the negative imaging of women in menopause. And so I look forward to seeing that in your talk, Martha. So thank you very much for coming.
Thank you, Melanie, and thank you so much for the invitation to be here. And I have to say, this does feel like home turf for me. This is what I do clinically, twice a week, and think about quite a lot about how we could do better. Oh, sorry. So these are my declarations. I've, as just mentioned, been working for the World Health Organization on the menopause and dementia projects for NICE guidelines. Recently been awarded funding from Wellcome on Alzheimer's disease and menopause. I'm an editor for the new Lancet journal. And one of the reasons I'm here at the moment is because of the International Research Challenge on Women's Cardiovascular Health that I'm co-leading with Cambridge. I'm also an editor for the Cochrane Collaboration, funded in the UK and Australia, and I don't take money from pharmaceutical companies. So I'm going to talk just briefly about inclusive language. I'm going to use the term women, but I recognise that menopause also affects trans and gender diverse people, and we know very little about menopause in that population. So why is this important to consider? About 4% of women are cancer survivors, and that's expected to double by 2040, partly because of improvements in treatment. And of course, treatment for cancer affects women differently from how it affects men. And I think we've explored that in the reproductive space a bit, but there's a lot more that needs to be done in that field. But we know that women are more likely to develop infertility or even have menopause from treatment. We know that certainly in breast cancer, the kind of symptoms that you get when you take your cancer treatment affect whether or not you're prepared to continue to take it. So that's a direct effect on mortality. And these symptoms exacerbate things that affect a lot of cancer patients anyway, like mood disturbance, depression, sleep problems, fatigue. And of course, if you have an early or premature menopause induced by your cancer treatment, then that itself has got long-term health implications. So I think it's an important area to consider when we're offering, thinking about cancer care. And also to make the point that it's not only survival from cancer that matters. And also, and I think increasingly this is something we need to turn our thoughts to, it's not just about women's cancers. Of course, breast cancer and gynecological cancers are an important cause of morbidity and mortality. But if you look, sorry, this is a bit old, but that's the latest I could get. This is the incidence of cancers in females in the UK. And you can see that the other category is still an important contributor. So what I'm going to cover is how to manage symptoms, particularly hot flushes and night sweats, also talk about sex, how to help with sleep disturbance, And I'll touch on the issue around brain fog and cognitive problems because that's very topical at the moment. And I'll also talk a bit about optimizing long-term health. You know, if we're doing something for these women, we should be thinking about what we can do in the future to improve their health. So I'll talk first of all about vasomotor symptoms, hot flushes and night sweats. So in the setting of a woman with cancer, there are different causes for these symptoms. And I think we need to consider that perhaps when we're thinking about evaluation and treatment. For the younger women, we might be giving them gonadotoxic chemotherapy. That will be common in breast cancer, for example. Gynae cancers, pelvic irradiation, which will very reliably stop ovarian function immediately. For those women, 25% of breast cancer patients are under 45. Nowadays, the standard of care for those women with ER-positive cancer is ovarian suppression plus an aromatase inhibitor, which is quite a brutal reduction in circulating estrogens. And of course, bilateral oophorectomy might be part of endocrine therapy for breast cancer, or it might be risk reduction for those women who are at high risk of ovarian cancer. So that's just the younger women. In the older women, an older woman with breast cancer will be advised to stop her HRT immediately. And that itself may lead to resurgence or onset of symptoms. And of course, older women with ER-positive breast cancer, which is nearly all of them, will be on estrogen blockers for what used to be 5 years, but now is quite commonly 10 years. So this is a growing issue. So this is an important discussion that I have with my patients, who will often say that they've been told that nothing can be done for them. There's no treatment that works. And that's not the case. There are things that work. And I'm going to draw on one of the papers from the Lancet series from 2024 that we specifically addressed this issue of managing menopause after cancer, if anybody is interested in reading that. So, of course, the most effective treatment is estrogen-containing HRT. And it appears that there are many cancer patients who are not offered HRT when they could safely, as far as we know, be using it. So part of our job in this clinical service is to make sure that those who could be taking it are offered it. And as far as we know, and Melanie knows much more about this, it appears okay to take HRT if you have BRCA1 or BRCA2 pathogenic variants, but haven't personally had breast cancer. And I'm just quoting a 2025 study that I think might have come out since you did the NICE guidelines on this, that if you take HRT for 5.6 years, it doesn't seem to increase your breast cancer risk. So that's great news for women with BRCA1 and BRCA2. And one of the things we put together for the Lancet paper was to try and hone in on when HRT could safely be used after cancer, because of this concern that maybe it wasn't being offered adequately. And we split it into cancers that males or females could get. And you can see we've tried to go through all the most common cancers. And you can also see that most of those women are actually eligible to take HRT. And then we looked at cancers that just affect females, breast, ovarian, vaginal, vulva, and cervical. And really, apart from some subcategories of ovarian cancer and breast cancer, in most of those cases, it seems to be okay for women to take HRT. So really want to sort of raise awareness of this as an option for those women who might benefit. I'm interested also in non-pharmacological treatments, because what I hear in the clinic is women saying, I don't want to take a drug to deal with the side effects of another drug that you're already giving me. And of course, so I think it's important that we've got the best range of options available. And actually the evidence on this, I think, has progressed quite rapidly in the last couple of years. When we did the NICE guidelines, we looked at the evidence for CBT, cognitive behavior therapy for hot flushes. Wasn't very convincing, but it was kind of tentatively recommended. And it does improve the bother or interference that women may experience. But the data on hypnosis is much better than CBT. And we didn't include it in NICE. I'm not quite sure why we didn't, but we didn't anyway. And in comparison, the hypnosis data shows a reduction in the frequency and severity of hot flushes, as well as the extent to which they bother women. And again, it's not been evaluated yet, but there is now an app that you can do the hypnosis on yourself. And I think it is a bit expensive, and it's, as I say, it's not fully evaluated. But if you don't have a hypnotist available, which we certainly don't, it's another option to be giving to women for something to think about. And I'm just put up this data from a paper from last year, looking at hypnosis for vasomotor symptoms and showing, a clinically significant reduction with the hypnosis compared to white noise, which was their comparator. So for women who don't want to take anything, there is something that can be done. And finally, on this non-hormonal area, I'm going to talk about a Cochrane review, which has recently been completed and not yet published, but with Cochrane, which is looked at which of the non-hormonal treatments works the best. And this was a big undertaking by Benita, who's my registrar. And here's the data. So what you can see is the only things that actually worked to what was considered to be a clinically significant extent were oxybutydin and estrogen. So this was unexpected for us, an unexpected finding. Of course, we included all the published data on fezolinetant and elinzanetant. And they did help, but didn't help as much as oxybutydin. So this and the other things didn't really work very much at all. So this has changed our practice very directly. We're offering oxybutydin as first line to women instead of who can't take estrogen. And then I feel that there's a genetic answer into who responds to the neurokinin receptor inhibitors and who doesn't, but we don't know that yet. We don't have elinzanetant. I don't think you have it yet either. The Americans have it. And of course, blush, we're eagerly awaiting the results. That will help us to understand with oxybutydin versus venlafaxine, a head-to-head trial, fantastic quality evidence to consider. So this is a big area in menopause and cancer care, which is to do with sexual difficulties. And we struggle with this, but we try to work through what can be done. And nearly everybody's got sexual difficulties, as it turns out. And ASCO, the American Society of Clinical Oncology, make a very broad statement that all of us should be raising the issue of sexual difficulties and offering counselling to everybody. And that's a big call given resources that we have. And I'm just flagging up the pelvic irradiation here because those women are at risk of scarring and loss of vaginal function. We recommend dilators in our practice with vaginal estrogen. Nobody's got any idea whether or not they work. And I'm increasingly seeing younger women with anal cancers who also get radiation-induced vaginal changes. So I think this is an area that really needs more research. So the vaginal estrogen does improve pain with sex and reduces recurrent urinary tract infection. And there's also some data on vaginal testosterone, but whether or not that's safe, we don't know. Lubricants and moisturizers, we all recommend them, but there's almost no evidence that they do anything, really. We ran a randomized trial of silicone versus water-based lubricants for women with pain after breast cancer. And the silicone one worked a bit better, but 80-odd% of them still had pain, even, with both of these interventions. So I think it's an area that, again, that needs more input. And I just make a point about vaginal laser. At NICE, we concluded, do not use outside of an adequately designed randomized controlled trial. And that was based on a number of studies, but I've just flagged up one there. of CO2 laser, which showed no difference between the sham, which is the appropriate comparator, and the laser. More recent Cochrane review showing no effect on urinary incontinence. And I think there are different sorts of lasers now. And ER, yeah, people are using, and it's different with a different laser, but I'd really reinforce that message. Don't use it unless it's part of a trial. I don't know whether this goes on a lot here, but you can tell me. So I'm also going to talk about sleep because this is such a big issue for cancer patients. And kind of interestingly, we looked at sleep in the WAM study, which is the cohort of surgical menopause, and we measured sleep at baseline before anybody had gone near their ovaries, and in our control group. And 50% of women had poor sleep quality before we'd even done anything. So it taught me to beware of cross-sectional data where really you don't know what was going on beforehand. But of course, sleep disturbance is really bad for people. And in the setting of menopause, it's the sleep disturbance that drives the depression. So, if you leave chronic sleep disturbance, then you will, many people will experience psychological consequences. So we try to be proactive for sleep. And actually, I know people shy away, but there's good data showing that the hypnotics are quite good for women who've had breast cancer, who have chronic sleep disturbance. Melatonin, little bit quicker to fall asleep. But really, the evidence for sleep disturbance is about CBT for insomnia, so online CBT. And the Cochrane review reported that this was effective. We've just run a trial in gynae cancer, which also showed that it was effective. I haven't, it's not yet available. And this is some of the work that we've been doing for sleep. This is not for menopause, this is for cancer generally. A program called Can Sleep, which is a stepped care approach to sleep problems. And this has worked well. We've just done a replica one for young people. So it's an online program and it's run by psychologists, and that seems to be effective. And I'm interested to hear whether you are doing similar kinds of things here. So I'll talk about now what we actually do in a practical sense, how we manage these symptoms, who comes along to the menopause and cancer service, what we do when they get there. So this is a multidisciplinary service, and it emerged from a regular menopause clinic where use of HRT dropped. So we had a bit of slack in the system, and I had a knock on the door from a breast surgeon who said, "Can you do anything for my breast cancer patients? This is terrible. Can you do something to help?" And I thought, we can, really. We can pivot and we can do things a bit differently. So we started with breast cancer, and then now we take all cancers. So cancer services, as you know, are often, or nearly always actually, tumor stream specific and can often be gender blind. And that's flagging my concern really about women with cancers like lung and melanoma and bowel cancer who perhaps are not getting appropriate care. We did a stakeholder consultation, it's quite a few years ago now, and said to the cancer patients and to the oncologists, what do you need? What's the problem? They told us that many women were completely unaware that their treatment was going to cause menopause. When they did experience menopause symptoms and reported those to their practitioners, they felt they were dismissed. They didn't feel heard. The oncologists felt unprepared to be dealing with this, that it was outside their kind of area of expertise. And when we asked our patients what they wanted, they said they wanted the symptoms managed in one place, common things, one place, one stop. They wanted it to be easy to get to because Australia has quite a rural population. They didn't want to have to travel 4 hours. So telehealth was kind of in the end was the answer to that. And they wanted joined up care between clinicians. And this point came up quite often of people saying, you know, I don't want one doctor to tell me it's okay to take something, and then my other doctor to tell me that's going to make my cancer come back, because we really need to talk to each other and be and offer that joined up care. So that's what we tried to do. All symptoms, all cancers, oncology referral, or a nurse or a GP. We don't have a self-referral system. We see people in person, or increasingly now, or with video telehealth. We've got guidelines by tumour type, which I'm very happy to share, patient information and support. And we've, in the last maybe 3 years, introduced multidisciplinary meetings. And it's been fantastic, because rather than a patient saying, I want this, and the doctor saying, I don't think you should be taking that, we can then say, okay, well, I'll go to the team and we'll discuss it, and then we'll see you again afterwards. And it's a model, of course, in cancer, which is used all the time. It just wasn't used in menopause, but it's helped us learn about cancer care a bit more. So I just wanted to flag the issue about brain fog. So I don't think anybody had brain fog a few years ago, but now everybody's got it. And certainly in cancer and the regular menopause service, we're hearing a lot from people that this is a problem. And the cross-sectional data, we don't have longitudinal data, but 70% of peri or postmenopausal women say that they've got brain fog. When we did the menopause priority setting partnership that Melanie alluded to, it was the number 3 of the top 10 priorities. So, you know, we know this is an issue. The objective studies of cognition don't show any change. And we looked in the BRCA1 and BRCA2 patients after oophorectomy, and we didn't see any change. They were all completely fine. But we didn't measure subjective cognition, and maybe we should have done. And I think what women are telling us about here is about subjective cognition. So we're still really learning about how to listen to that and how to measure it and how to offer help, so that's, again, interesting to hear what your experiences are. So we have a multidisciplinary team. It's not very large. I mean, it looks like a long list, but only 4 of them are in the clinic. The gynecologist, endocrinology, really valuable for bone health, a GP who also has some expertise in sexual counselling, and then the nurse who coordinates the clinic. And we're just working closely with these other existing services, just making sure there's a conversation between them. We do have electronic medical records, which I think probably makes it a bit easier to have that kind of contact. And of course, we work with patients and with advocacy groups. So trying to offer joined up care across cancer types. And I just looked at who came to the clinic before I went away. And we started only with breast, and it later opened up to other things. And you can see that breast is still a large proportion, but it's not all. And, you know, gynae cancer are second largest, and BRCA obviously a big group, and hematological cancers, who we see because they get menopause induced by their conditioning chemotherapy, and they are at risk of genital graft versus host disease if they've had an allograft. And so that's become a bit of an interest. The hematologists don't want to put a speculum in because it's not their, that's not sort of their territory. So we try and pick up on that because it can be hidden, of course. So there's been, I recently was in Singapore where they were opening their MSAC service there. And overall, there's been 7 countries now that have these services. We all like it, actually. It's much more interesting for the clinicians than just doing menopause all the time, because there's lots of variety and lots of questions to ask. And our patients are happy because otherwise there wasn't anybody to see them. We did show in breast cancer that women managed with this service were more likely to take their endocrine therapy. So that potentially has a knock-on then for morbidity and mortality. So that was good. And I've just updated this from a BMJ publication in 2017 with the more recent evidence about the non-hormonals, with the order in which we'd suggest using them, given their efficacy. and then a mention to the vaginal symptoms and the possibility of graft versus host disease. And I've moved the arrows around that I put hypnosis and CBT on the same level because I think they're at least as good as each other, and maybe the hypnosis is even better. So that's been an exciting development. And this was a flowchart we did for NICE about managing genital urinary symptoms after breast cancer, which is a very fraught area about can you or can you not give vaginal estrogen. And I think the conclusion at that time was not first thing, but if nothing else works, then you probably can. But in Australia, we've recently looked at we're developing our national guidelines, and it looks like the risk is higher with aromatase inhibitors. So maybe it's not completely safe for everybody to use vaginal estrogen in terms of the most recent data. But that's another discussion. And I'll just talk briefly about high-risk women. So this, Melanie mentioned some art project. I've ran a project called Flesh After 50, which is about trying to give more positive images around aging in women. And this woman's got BRCA1, and she's written underneath her breast fake, and she's written above them, the real ones tried to kill me. And I think that's really that's the kind of thing that these women are dealing with. This is a complicated, and whatever they do, it's going to cause problems. You know, the options are not very great, are not great. So I'll just mention the WAM study. So this is a prospective study of premenopausal women prior to their risk-reducing salpingo-oophorectomies and a group of age-matched controls. And so far, we've followed them up for 2 years, and 60% started HRT. We've just got funding for a 10-year follow-up, so that I think will be more informative. And the figure here just summarizes what we found, which actually was not very much. We expected to find more symptoms and more severe symptoms than we did find. And I think, concerningly, in a way, for those that took HRT, it kind of helped, but it didn't help all that much. So your hot flushes or your sleep disturbance did not go back to what it was before you had your ovaries out. And perhaps it's been a kind of an arrogance of gynecology that we think we can take some organs out and chuck in a bit of estrogen and everything's going to be fine. And it doesn't seem to be like that. So we'll see at 10 years what's happening, particularly for cardiovascular and brain health. And this was a consensus statement about after risk-reducing salpingo-oophorectomy, because those of us who were involved in writing this felt that it was a bit underdone. And then I think NICE came up after that. But the conclusions are the same. And for bone health, of course, which is so important, Poise, your study will help teach us what we should be, how we should be preventing bone loss and preserving bone health. So for the BRCA1 and BRCA2, and I just spoke to somebody before who works in Lynch as well, because our patient, we found that our patients were avoiding risk-reducing surgery because they were scared about surgical menopause. We wanted to provide some written information that wasn't about cancer. The cancer stuff seemed to be well covered, but this was specifically about what to expect when your ovaries are removed and what symptoms you might get and what can you do about it. So we give this to everybody who is having risk-reducing surgery. And then I'll talk briefly about tuber wisp. So this is a study trying to answer the question, or one of the studies trying to answer the question, can you just take the tubes out in the setting of BRCA1 and BRCA2? This is led by Radboud, who are a Dutch group. And it's been very, it's just described here. So it's kind of quite a young starting age for BRCA1 and BRCA2. And it's a patient preference trial. So the women decide which intervention they want to have. And then we follow them up to see what happens. And the primary outcome is high-grade serous ovarian cancer. So it's the clinically important outcome, but it takes, just saying to Adam, a long time. So this is the current state of play for tubal wisp. These are the groups around the world who are participating. 67 groups in 16 countries. They've done really well. We've got 2,700 out of 3,000 participants already recruited. So that's great, but it will be 10 years. They're expecting 10 years before we'll get the clinical answer. So another area that I've been working in is around vulnerable populations in the setting of cancer. And in particular, the LGBTQI plus population. And we were really surprised how little there was about the experience of being diagnosed with or treated for cancer in that group. And on the back of a mixed method study called Out with Cancer, led by my colleague Jane Usher, we interviewed large numbers of patients and their carers and their clinicians about what the barriers were and what we could do to try and improve their experience, because they do have an increased risk of some cancers and they're less likely to participate in screening, for example. And out of that came this booklet, which is now circulated around the country. And we're hoping, lift some awareness, some more clinicians are wearing badges or something to indicate that they're friendly towards these groups. And it's small things that I hope will make a difference. So just to summarize, then many cancer patients experience menopausal symptoms, and there are effective treatments out there, but they're probably a bit underused, including hormonal treatments. We've had a great experience, I hope the patients have, with multidisciplinary care, because it's patient focused and it may even increase their adherence to cancer treatment, as well as hopefully improve quality of life. I think we need to consider vulnerable groups, and I've mentioned the LGBTQI plus group there, but I'm increasingly alarmed about what's happening to women who are having cancer treatment in the more mainstream non-female specific cancers. And we've tried to create a research platform to make sure that women's voices are being heard in the discussion and the delivery of their treatment. Thank you.
Thank you.
Any questions, Martha?
Yeah, great. Right.
Just ask, I'm not a gynaecologist, I did start as a gynaecologist. We work together in Northwest Heads. What about other sort of therapies like things like acupuncture or exercise? Are any of those that are, because they're often sold as being good for well-being, but is there any evidence for sort of symptoms?
No, there is evidence, and the evidence is negative. So certainly for exercise and acupuncture, they don't seem to help with hot flushes. In the general population, there's a possibility it could be different in a cancer population. And, I hear what you're saying. I think that we really need to be listening to patients saying that they don't want to be taking more and more medication, and there should be other options on the table.
Yeah.
Thanks, Martha. That's fantastic overview. I guess the two surprises for me was the oxybutynin information, which I wasn't aware of. I'm going to put my cynical hat on and say that when I was a medical student, it was clonidine was the only thing that could give people equivalent hormones, and that was pretty rubbish. And then it became the SSRIs, and everyone was very optimistic about them. And those GPs actually started giving that as well, as my experience. And then now you've actually found it's a really old-fashioned drug from another indication that is effective. And I just wonder if people have been seduced by the sexiness of SSRIs and now Lancet as well, and actually seeing of an old, presumably very cheap, actually might be the most effective. So that was just a comment. Just wondering how much the kind of pharma influence might have played into that awareness as to what's actually effective.
Well, nobody has promoted oxybutynin for this indication, and probably they're not promoting it for any indication because it's so old that it wouldn't be an incentive. But there is an incentive for for promoting the new neurokinin receptor antagonists, because they're new drugs and so on. And it wasn't, I can put the table up again if you like, but they both worked. It wasn't that the fezolinetant and enzalutamide didn't work. It was just that when you put them through the rigor of a Cochrane review and try as much as you can to standardize what they're actually measuring, they weren't as good. They weren't as good as oxybutynin. And if you look across, the clinical effect size was large. So and small for the other one. So it was in our practice, women have to pay more if they're taking fezolinetant. So it had become a little bit of a sort of equity issue already. So it's helped us to know that there's something that's cheaper that might still work.
A word about the blush study, because NIHR have given us a lot of money to run a head-to-head comparison of oxybutynin against standard treatment. And in the UK, standard treatment is SSRI, SNRIs, which don't come off very well in your review. But I think it's going to be quite difficult. No, I think it's going to be very difficult to recruit, because we've got the MRHA license for fezolinetant, and now we've got NICE approval. Came through
Yes, I saw that. Yeah.
And it's now going to be very widely marketed.
Yeah.
And all around the country, all of the menopause specialists are saying, "Can I get this onto my formulary?" And people aren't terribly interested in oxybutynin; they haven't heard of it. If they have, the association is with side effect profile.
Yes, that's right. So I think we'll be publishing this in the BMJ once it's gone through Cochrane, and because I wanted to reach GPs who are probably the main people who are having to deal with this.
So the bracket data you've done on the WAM study, is sort of really counterintuitive to what we all hoped, I guess. And
let's get onto the diagram.
Presuming you did control for things like whether patients who had breast cancer or were already menopausal and these kinds of issues.
Oh, they didn't get in if they were all premenopausal at the start, so that was part of the criteria.
So two things occur to me. One is if no one's done a study in BRCA carriers where there's a BRCA negative control, is it that BRCA carriers are already suffering a lot of detrimental symptoms just because they're so stressed about the situation? And therefore, maybe that's why you don't see such a big improvement.
No, because we looked at, we published it and put it all in, but at baseline they were all almost identical. The control group and the BRCA carriers. BRCA carriers were a bit heavier. That was the only thing. BMI was a bit up, and CRP was up for a reason we've never managed to understand. But otherwise they were the same, and you saw these things, going off really quite quickly. I mean, 80% got hot flushes and sweats by 3 months, but nearly all of them said they were mild, which I didn't expect really. So no, it has been a bit counterintuitive, and the cognitive stuff we weren't expecting, but 10 years we might be different.
No, sorry, any questions online? No questions. Well, thank you very much. I mean, for those who don't know me, I'm Anna David. I'm the director of the Institute of Women's Health, and some of you may know that I had breast cancer about 15 years ago. And I vividly remember standing in the tube line thinking, this is so hot that I'm getting. And it was the third time that it happened, and I just started taking tamoxifen. And I was a bit, oh gosh, you're so stupid. I mean, call yourself a doctor. Why are you a gynecologist? And you have no idea that you're having hot flushes. And I was like, nobody mentioned anything like this to me at all. So I wish your reviews have been available when I was going through all of this, because it did make life very, very difficult.
Yes.
It's so thin. You are sweaty at night, you're not getting a good night's sleep. And then, you just throwing off all the sheets and thinking, gosh, do I really want to carry on to what's going for another 5 years? And then you go 5 years and they go, yeah, now there's new evidence to show that you've got to do it in another 5 years. You think, So
Yeah, and most, you know, a lot of women, maybe 40%, don't continue their endocrine therapy because it's too long and it's too awful, and they just, you know, it's a long time.
It's a long time, and I was a bit like, and the gynaecologist said to me, you know what, there's a new trial out, you've got to take it for another 5. I was like, oh, thanks.
Yeah.
But yeah, fantastic. And thank you very much for, you know, setting up collaboration with UCL and for all the fantastic work and international work as well. So
Thank you. Thank you. Yeah.